Well, thank you everyone so much for joining the virtual chat with the expert today. With us here, we have Dr. Erica Cotton, as we're going to discuss a little bit about epilepsy and mental health. Dr. Erica Cotton is with us here today from Northwestern Medicine as a psychologist and a neuropsychologist. And I will actually pass it over to you so that you can share your screen and begin your presentation. If anyone has any questions, feel free to utilize the chat and we'll go through it. This session is recorded as well.
All right. Hopefully you guys should be able to see the normal view, not the presenter view, right?
Yes.
Perfect. Okay. So thank you so much for that kind introduction, Alex, and for inviting me to talk tonight. I think this is a really important topic and one near and dear to my professional heart. Disclosures, none, or conflicts of interest, none, but I will say, Alex did warn you I'm a neuropsychologist. So while this talk is on mental health, I will unapologetically include some brain-based explanations. I wouldn't quite do my field justice if I didn't talk about how mental health relates to the brain, which is an area I'm particularly passionate about, especially for people with epilepsy, because I think it presents some really unique challenges that aren't well recognized within the mental health field or within the neurologic field. But hopefully we can change that one step at a time. So the first part of this talk, and I'm just going to kind of take it by time in terms of how far we get through things and keeping in mind people's questions. But the first part, I really want to focus on the basic mechanisms and models for mood and general mental health in epilepsy. And then I want to talk about some of the common causes for mental health challenges for patients with epilepsy. And then some of the treatment barriers and options for mental health. And I think this is really important for people with epilepsy at all levels to understand and be aware of so that we can all be better at navigating the systems and challenges that are available. And I think there's no secrets here. And anything I would share with my colleagues, I would be happy to share with a patient with epilepsy and vice versa. I think that should be fairly transparent. So let's first talk about epilepsy. But one reason why I picked this definition, it's from the International League Against Epilepsy and their task force. But I appreciate this one because it not only characterizes that obviously epilepsy is an enduring disposition to generate seizures, but there are neurobiologic, cognitive, psychological, and social consequences of this condition. And I specifically emphasize the psychological consequences because this often refers to the comorbidities, so to speak, the psychiatric comorbidities that in this definition are assumed to be a complication of the seizure disorder itself. There's not the seizure disorder and then this black cloud that kind of hangs out outside your head that causes problems with mood or daily functioning. They're intertwined. They're the same thing, and they're coming from the same thing. So how common is this? So about a third of patients with epilepsy will have a quote unquote psychiatric comorbidity. But a giant disclaimer on this, and part of my latter slides, which is that comorbidities in epilepsy, particularly with mental health, are not well assessed. So this likely represents an underestimation of the amount of comorbidities that are present from a mental health standpoint. Basically, the rates of anxiety and depression are probably higher than 1/3. But even with that 1/3 that we at least ask and acknowledge, there's a lot related to the negative impact of seizure disorders in terms of its treatment and the role that having a mental health comorbidity for people with seizures that I'll talk about in later slides as well. Now, when we talk about psychiatric comorbidity, there's lots of fancy terms for it, depression, anxiety, but then there can also be more rare ones like psychotic issues as well as attention deficit issues. And oftentimes there's a close and complex relationship between a person's seizure disorder and their mental health comorbidity. And hopefully that will become clear as I talk more about some of the neuroanatomy involved. But the other piece that I highlighted on this slide was there's no systematic approach for evaluating mental health comorbidities in patients with epilepsy, which means that we might not have it really well characterized, and we might not have the accurate breakdown of percentages. And we also don't know how that breakdown or percentage might be different in different regions for different people at different stages of their lives, for different people across different genders. There's so many unknowns regarding the prevalence rates and lack of specificity regarding the prevalence rates. 1/3 of patients with epilepsy is a really broad stroke, and there's much work to be done to further outline specificities for people with epilepsy and mental health challenges. I like this slide. I think it really applies to anyone with mental health challenges, especially with people with epilepsy. Essentially, nobody thinks, well, I shouldn't say that. We've all had challenging interactions with people who don't understand or themselves are the victims of bad programming. But essentially, it's not in your head. People aren't crazy. The brain's a very real organism, and it is a functioning organ that when it goes wrong, things don't work right. And the brain's responsible for emotions and behaviors. And if that organ is experiencing dysfunction, it's only natural that then there would be a dysfunction related to one of its outputs. So let's talk about the most common causes, and then I'm going to delve into the first one more. So one of the most common causes for mood and mental health comorbidities in epilepsy is simply the networks that are involved, the brain networks. As I said, the brain is a very real organ. It has very real functions. Different pieces do different things. And there's a real connection between a person's epilepsy, where that epilepsy is, and what symptoms they could predictably experience as a result of having their seizure disorder. And I will talk at length about that. Secondly, there's medication side effects. Medications to control epilepsy also change the neurochemistry of the rest of the brain, including the brain that is responsible for producing and regulating emotions. There's also the fact that just having seizures is hard. Seizures are awful. They're not pleasant, and they generally have nothing but a negative impact on a person's life and their well-being. And that can impact mood from the outside, from the fact that it changes a person's life. So you have an internal, from a brain impact perspective, you have medication side effects changing the brain chemistry. You have the fact that life changes due to seizures. And then taking it even broader, more externally, seizures don't exist in a vacuum. And unfortunately, just because an individual develops a seizure disorder doesn't mean that magically family conflicts are resolved, or that families magically become supportive, or spouses become supportive. I wish it worked that way, that, all right, you have seizures, no more hardship, or you get all the support you need, but that's not often the case. Sometimes it is, and that's great, but sometimes it's not. And for individuals who don't have social support, that can be really hard in the setting of epilepsy. Epilepsy changes people's lives, and if there's not someone to help buffer that change, it can really produce normative and realistic challenges for a person's mood and adjustment. And all of the above are not mutually exclusive. Mutually exclusive just is a fancy way of saying they can all occur. Having one does not mean you are immune to having the other. And that all of these things can occur and build on each other in a consecutive way, or in an iterative way where they add on top of each other. And as I highlighted, and I'll kind of routinely highlight through this, because I think it's helpful for anyone working in the epilepsy field or who has epilepsy to be aware of the fact that there is an under recognition, and therefore there's going to be a lack of dedicated services, structures, and supports targeting patients with epilepsy who might be struggling with mental health challenges. So now I'm going to be a neuropsychologist briefly. Humor me just slightly, but I have a good reason. So the way that I completely think about mood disorders and mental health with epilepsy, when I was asked to give this talk, my initial response was, well, of course I have to talk about the limbic system. But for those of you not familiar with the limbic system, or even what's to the right of my screen, so you're looking at a brain. You're looking at the side of a brain, but what you're seeing is through to the middle part of the brain. And if you can see my cursor, which I think most of you can, should be able to see my cursor here. Most epilepsies, as I'm sure a lot of people are familiar, happen in the temporal lobe. Middle temporal lobe epilepsy. It's the most common place to get epilepsy and have seizures. Seizures come generally from a certain part of the brain. Sometimes it comes from all over the brain or is multifocal, meaning it comes from multiple places. But the majority of epilepsies come from this region in here. This part that's highlighted, that's shown, sitting really within the brain. It's deep in the middle of the brain, and the rest of the brain sits around it. So our temporal lobes here, our occipital lobes back here, our frontal lobes up here, our parietal sits kind of in the middle. Briefly, our occipital lobe deals with vision. Our parietal lobe helps support vision and movement. Our frontal lobe, our temporal and middle temporal lobes do a lot. They're more evolutionarily advanced. These are the pieces that make us human. Our temporal lobes, especially on the left, help support language. But in the middle temporal lobes, this is where our hippocampus and our amygdala live. Our hippocampus is responsible for helping us store and consolidate memories. And our amygdala is the part of our brain that helps us with emotions. It's our threat detection and orienting piece. It helps register emotions, and it helps tag our memories with emotions and our experiences with appropriate emotions. And then our frontal lobes, we'll talk more about those, but if you think of the frontal lobes, there's motor system in the back part of our frontal lobes, which is why people with seizures might shake or have motor changes because that part's being activated. But the frontal lobe part that I'm going to talk most about is, think of it like an executor or an executive, CEO. It deals with our higher order thinking, the things that make us very human, like abstract reasoning, our ability to construct or plan or organize. Anything that you would think a CEO of a company would need to do, that's what our frontal lobes do. Direct attention and resources here, don't direct it there. An important piece to remember is that our temporal and frontal lobes often have supportive and at times competing aspects. So our temporal and middle temporal lobe, where a lot of epilepsies happen, are really activating or impairing memory networks and our emotional networks, as well as our ability to self-regulate those pieces. And there's a big connection between the middle temporal lobe and our frontal lobes. Because they're so evolutionarily advanced, they talk a lot. There's a lot of connections between these two, and I'm going to talk about why. Here's an example of depression. This talk is about mood disorders. And again, you can see the same orientation of the brain here. And in healthy individuals, our middle temporal lobes and our middle part of our brain is generally fairly under wraps, meaning it's not very active most of the time. It's always registering and forming memories, but the emotional piece is usually pretty well controlled so that we can focus with our frontal lobes on the things that we want to do. So if you think about our middle temporal lobes as the thing that helps us remember what's happening, but then emotionally focus on our emotions ourselves, turn inward, possibly ruminate, possibly feel anxious, possibly worry about that, versus our frontal lobes that help us plan, goal direct, solve problems. What do I want to do? How do I want to get that done? Who can I recruit, right? And generally, these two are in a healthy balance. Let's say you get an emotionally provoking thing. Oh my goodness, I need to do that. Oh, well then quickly your limbic system might get activated. Your middle temporal lobe might spike a bit, but then quickly your frontal lobes take over and say, all right, hold on, we've got this. Let's figure out what we need to do about this. Let's figure out how to sort this out. And it takes over. Now in depression, what you get is an overactivation of some middle temporal lobe pieces and some midbrain pieces, and you get a deactivation of the frontal lobes. So then what you get is someone who much more than likely is struggling with an internal focus. Gosh, what did they think of me? Gosh, I hope I'm doing okay. Do I feel this way? Why do I feel so bad? Lots of internal focus, especially bringing in memories, remembering something bad that happened or predicting something bad that might happen in the future. What if this happens? What if that happens? Oh my goodness, I can't stand if this happened again like that. And so drawing the attention back inward, then you're not able to be, well, hey, what's the problem? How do I solve this? let's figure out what to do. Let's tackle this with the frontal lobes. Now, why does this matter with epilepsy? If you tracked with my last slide, essentially epilepsy creates a pattern very similar to a depression network, which is there's an overactivation because epilepsy is creating too much excitability within the middle temporal lobes and within the networks responsible for mood. And generally it deactivates the frontal lobes. So if we go back, oops, there we go. So if we go, So if we go back, you get things going in the wrong direction. You get an increase in limbic system activation and dysregulation in memory, self-referential thoughts, emotional activation, emotional regulation. And then you get usually with epilepsy, a decrease in frontal lobe functioning. So you decrease how well you can problem solve, redirect your attention, shift off the topic. And that's generally two things moving in a bad way. You get an increase in all the negative sense of experiences, depression, sadness, rumination, worry, fear, and you get a decrease in the brain regions that help you get out of that rut and help you solve the problems or help you feel better, which is oftentimes one of the hypotheses for how epilepsy, especially temporal lobe epilepsy, creates mood and emotional challenges based on the networks that are activated in unhelpful ways. And ironically, most of psychotherapy focuses on down-regulating this limbic system and up-regulating, increasing the problem-solving and helpful responsive networks of the frontal lobes. Now, why does this matter? Who cares? Well, one, the person experiencing it definitely cares, but also it's not just, as I said, a black cloud. So a history of depression before or after epilepsy is associated with an increased risk of treatment-resistant epilepsy. And there's some theories on that. The main theory is that if an individual is having mood issues in addition to their temporal lobe epilepsy, that might mean the epilepsy network is stronger or more widespread, especially if it's pulling in the frontal lobe functions. That might mean that the epilepsy network is worse for a person who has additional symptoms other than just memory impairment or other than their typical seizure semiology or how their seizure typically looks. And that might mean that it's harder to treat because it's more ingrained or more widespread. Also, people who have this network involvement are at greater risk of having side effects related to anti-epileptic medications. Those medications interact with the chemicals that support the limbic system and the frontal lobes. And if a person's already dysregulated there, well, then medications might not react or play as well with those sorts of issues. So generally, people tolerate their anti-seizure medication less well, meaning it's harder for them to tolerate the side effects. They might experience more of them. And unfortunately, there can be an increased risk of suicide for people with depression or anxiety or mental health challenges if they also have epilepsy. And I could spend a whole talk just talking about suicidal ideation, what it is, how to manage it, especially as it relates to epilepsy, and that could be its own talk. I don't have time to go into that in detail today, but it's highly relevant to people who are routinely experiencing mood impairment as a result of their seizure network or side effects or psychosocial circumstance in addition to their epilepsy. And obviously, individuals who have mental health comorbidities have a much poorer quality of life. And this is the part where I feel like it's important to be transparent about where our field's at so that individuals seeking mental health support dedicated to epilepsy have an understanding about where we're at. And essentially, as you see, this was a special issue in Epilepsy and Behavior. Epilepsy and Behavior is a common journal that epileptologists and those who practice in the field of epilepsy publish in. And in 2019, there was a special issue, which means there's multiple articles, which is pretty uncommon. It means this is an area that's really important for us to pay attention to, and we want to dig into it in more detail. And essentially, this was about treating psychiatric comorbidities and recognizing mental health comorbidities in epilepsy. And if you notice the things in bold, right? What's wrong with this picture? How big of a problem is it? What are the facts of the brain that are creating some of these mood disorders? Why aren't we more aware of them? Do we screen for this? This is unrecognized. You only recognize what you know. Are we deliberately choosing not to recognize this, or are we just in denial? And then even after epilepsy surgery, where are the mental health care professionals? And this was very recent and highly regarded as an important issue and topic for individuals working with epilepsy and for individuals seeking care, which if you're trying to find resources, know that those pathways might not be available, and you might have to be more creative around the ways that you request care and the ways you seek resources. And I have a slide about seeking care, ways to seek help, and what to explicitly look for. So there are very significant obstacles. So oftentimes there's a disconnect between psychiatrists and mental health professionals and neurologists. Sometimes we work in different departments. I'm fortunate enough to work in both departments and be present in neurology. There's usually a lack of training in neurologists in recognizing and characterizing mental health comorbidities. And there's sort of globally poor access to mental health care for a variety of conditions. And then there's different healthcare and institutional landscapes. What one institution allows to go together or work together might not work for another institution. It might not be financially profitable. It might, lots and lots of red tape across healthcare and institutions. Which is why seeking out more dedicated services, especially within the community, like the Epilepsy Foundation, are so important and crucial for closing some of these healthcare gaps and pushing us towards better acknowledgement. So we want to be sure to include screening tools, medications, and guidelines for referring and increasing mental health comorbidity, increasing access to treatment for patients who have epilepsy and might also be struggling with any mental health feature. So when you're considering mental health and epilepsy, you want to consider first the history, if someone had it before or after epilepsy, as well as what was the timing of it. Did it get worse? Did it get better? Does it get worse or better around seizures? Or is it related to something in the environment, a particular circumstance, a person, a relationship, which can then help guide the treatment planning as well as the management, as well as the type of psychiatric comorbidity. That can help inform what sort of treatment might be best, whether it's a mood or anxiety disorder, or if it's a psychotic disorder, an attentional issue. And if you recall, in our network discussion, mood and anxiety from the limbic system, and ADHD, meaning the frontal lobes, attention deficit hyperactivity disorder, is a disorder of the frontal lobe. So frontal lobes not working as well, combined with mood and anxiety issues, mean that it's harder to regulate those mood and anxiety issues. Psychotic disorders can happen for a variety of reasons, but they're much, much less common. By far, mood, anxiety, and attentional issues are the most common comorbidities. Okay. Now, you can get screened with your neurologist, which ideally should be happening, but it's not always the case. It's not a gold standard practice at level 4 epilepsy centers. Ideally, there will be a clinical interview with a psychiatrist or a psychologist or another mental health professional. And neuropsychological testing, usually for cognition, but also that assess mood and personality pieces, can be helpful in catching some of these mental health comorbidities. So who are all of these people? What do they do? So lots of different people can be involved in care. Neuropsychologists like myself generally focus on cognitive and psychological assessment. We get down into the weeds of the numbers. We look to measure things and understand things. Psychologists broadly generally perform incomplete psychotherapy. I also do that as a component. Psychiatrists are a medical doctor who prescribes medications, and generally they are involved in managing the comorbidities and are very helpful for people who have more severe mental health issues, because they can help with medication management as well as getting tapped into more significant programs like inpatient psychiatric hospitalization or more robust treatment programs if necessary. But the epilepsy training can vary wildly. People may or may not be familiar with it. They may or may not be familiar with the brain networks that underlie mood disorders and epilepsy or the specific comorbidities. So as I've talked about, there can be depression and anxiety. There can be psychotic symptoms, but there can also be emotional dysregulation, meaning a person just might have more difficulty controlling their emotional responses. They might be over or underreactive. Similarly, they might be overly or underly behaviorally active. They might do too much or do too little in response to their seizures or in response to their mood. Interpersonal dysfunction can happen. That can happen before, during, or after having seizures. And it it's not mutually exclusive with having epilepsy, meaning just because a person has epilepsy doesn't mean all interpersonal, which is interpersonal just means the way we interact with each other as humans, ideally, respectfully, kindly, assertively, that isn't always the case. And that can be a real problem for people with epilepsy. Combine that with cognitive concerns that make it even harder to regulate mood, regulate emotion, regulate behaviors, interact and understand and communicate with other people. And you get this complex web of interactions. I talked about psychotic symptoms as well, but as I said, it's a much lower frequency, and we'll just briefly be touching on those. But the last piece, and I hate that this part is present, and it's always just it's somewhat shocking to me every time. I think I adjust to the realities of pieces, but individuals with epilepsy are not immune to having a trauma history. Individuals could have been abused with epilepsy, could be abused as children. They could have experienced a sexual assault in college. They could have been groped on the train. And having epilepsy doesn't preclude preclude an individual from experiencing other very traumatic elements of life experience, which is always very sad because then there's two things to be dealing with or potentially be navigating. And then in addition, sometimes aspects related to epilepsy can be traumatic. If you had a traumatic seizure, if you had a traumatic hospitalization, if you were diagnosed under traumatic circumstances, that can be another piece that plays into mood management, emotional regulation, behavioral regulation, interpersonal functioning, and how well a person's able to seek and utilize their resources and to help navigate having epilepsy. Okay. For individuals, given, as I've highlighted, our field is by far perfect from having very clear established pathways for people with epilepsy as a gold standard, especially within epilepsy centers, which means a person with mental health issues and providers seeking mental health resources for their patients need to have some tools at their disposal and need to make their own pathways for their patients to get treatment. So generally, at least within academic treatment centers, there's some recognition of the comorbidities and some pathways for patients with epilepsy to get screened, evaluated, and treated, ideally. Usually that's best done in a multidisciplinary clinic where epileptologists, psychologists, neuropsychologists, psychiatrists can all talk about a person and what they are experiencing and the best way to help a person with epilepsy who's also having any neurobehavioral or mental health challenges. But that's not always the case. Everyone doesn't get care in a giant academic medical center, and smaller healthcare systems see patients with epilepsy, and those patients with epilepsy are not immune to having mood disorders just because there's not a dedicated person or a treatment. So this can result in more disconnected services and providers who are even less familiar or less specialized, in which case using social work and consultation is really important for patients and providers to gain access to mental health providers. And especially in much more rural areas where there's limited awareness, you oftentimes want to consider at least evaluation at a larger center that's familiar just for the evaluation, and then perhaps coordinating with providers closer to home or closer to a more convenient resource for the plan that's been created by someone very familiar. It's better to always have someone familiar creating a plan or someone knowledgeable creating a plan than having a plan be created by someone who doesn't know what the best thing would be. And it's always easier to get an evaluation and then have follow-ups tailored to that, because then you can always have that expert involved in the care versus going to someone expecting them to know everything and then finding out later on that they didn't recommend the right treatment because they weren't as knowledgeable or weren't as aware. So always best to kind of start at least with an evaluation with someone knowledgeable. There's this great workbook. It's available. I can't say which online retailer, because then that would be a bias, but there's a large online retailer that quickly delivers things, usually within a day or two, where this workbook is available. It's available in hard copy as well as in an electronic form. It's specifically for individuals with seizures, and it specifically addresses the behavioral and mental health components. It's ideally best completed with a trained therapist. And finding a trained therapist, you can again, advocate for yourself, and providers can advocate for interacting with professionals who are trained in health psychology. This is also called behavioral health or behavioral medicine. So health psychology, behavioral medicine. Providers who are familiar with chronic pain and fatigue are actually great. They might not be as familiar with epilepsy, but they get the body and they get generally the toll that having a chronic medical condition can take. The modalities of therapy are what we would, in my profession, call our alphabet soup: CBT, DBT, and ACT. Those are just shorthands for cognitive behavioral therapy, dialectical behavioral therapy, and acceptance and commitment therapy, each of which are focused on different pieces. I can go into that if people have specific questions about the differences. There are some unique differences, and I think some unique applications of each of those modalities to individuals with epilepsy and the type of issues they're having. And I'd be happy to share that if anyone would be interested, but I also don't want to go down a rabbit hole. And so when trying to identify mental health supports, you can make sure that you have someone who checks these boxes, or that as a provider, you're referring to someone who checks these boxes as a provider. And you can suggest focusing on seizures. Obviously you're not asking the therapist to cure a person of seizures, but you're asking to help them adjust in the best way possible, the most adaptive way possible to their symptoms. And oftentimes collaboration between a diagnosing or treating provider and a counselor or mental health expert is best. It's always better when people are talking and on the same page. Okay. With this last little bit, there's some repetition built in, but I want to leave plenty of time for questions and comments or concerns. But this last bit is on epilepsy surgery. So epilepsy surgery is very relevant to mental health as well. And I'm just going to quickly move. Well, no, I'll show you pictures of the brain in just a moment. Sorry, it's the neuropsychologist in me. But essentially, if you can imagine what epilepsy surgeries do, they take out part of the brain usually, which, as you can imagine, might change how it works, or might change how different networks operate. And so if the most percentage of epilepsy is middle temporal lobe epilepsy, that's responsible for limbic and memory, and then we take out those parts, well, memory and emotion might not work as well anymore. Now, it's a little lateralized. Left is language, right is visual spatial, and right has a little less risk than left, which has to do with our verbal memory. But essentially, these surgeries can significantly alter a person's mood, as well as their networks responsible for supporting mood and building behavioral regulation. So I'm just briefly going to walk through some of those pieces and reiterate a few different things. So for epilepsy surgery, as I'm sure most people on this call are aware, that a lot of patients with epilepsy experience intractable epilepsy and require epilepsy surgeries. And with those, roughly 30 to 40%, so 1 in 3, 1 in 2 nearly, experience postoperative mood changes. And that might be because they had it before or they develop it after. But also about 20%, 1 in 5, develop new experiences related to mental health. And this can be from, all of these pieces can happen either as you take something and you make it worse, something that wasn't there right before surgery but was there in the past comes back, or it spontaneously develops. And that can happen if there's a lifetime or family history of mental health diagnoses, aka there was something atypical or vulnerable in the limbic networks that we're then poking around or resecting in. And that's where the pre-existing mental health diagnoses might be highly relevant. Now, it's interesting in that the base rates of mental health disorders, as I said, it's not well stratified. So 1/3, 1/3 of who? All patients with epilepsy. But when you actually look at the literature on 1/3 of patients with epilepsy, but roughly 1/3 of those have intractable epilepsy, which likely means the epilepsy is worse. It might be more widespread. They're more likely to get a resection. The likelihood of having a mental health diagnosis with intractable epilepsy is much higher than the general base rates of mental health for all epilepsies, such as one that's not intractable or well controlled on medicines or hasn't been significantly life interfering or resulted in a neurosurgery. So estimates are as high as 80% of people with medically refractory epilepsy will have a psychiatric diagnosis. And you could argue, I don't think there is a clear answer of, well, is it just because their epilepsy is so bad from a neurobiological standpoint? Is it because they're having ongoing seizures is just so awful, which is obviously very relevant and a possible consideration, or they're on more medicines? Usually people with intractable epilepsy are on much higher doses, many more medications. And then there's an additional burden on the brain. I think it's all of the above. But the bottom line is the risk factors for mental health continue to increase the more intractable epilepsy is, and especially if there's a neurosurgery involved. So as we talked about, and I'm bringing back our brain schematic here, but in an epilepsy surgery, what might happen or commonly happens is part of this middle part of the brain is removed, either on the left or the right. And so a section relating to formation of memories, emotional regulation is changed or removed, and you have that changed on one side. The other side needs to compensate, but it's not what it was meant to do. So it can pick up some of the slack, but not all. Or if there's a resection that involves middle and partially frontal, or a frontal middle resection, whether it was anything related to an insult, an injury, like a TBI or a tumor is pretty common, then you're getting removal of part of the executive control network, which helps keep things organized. And so I appreciate this diagram because it shows that there's this sort of moderating and somewhat mitigating, mediating effect of cognition, meaning how well a person can think and use their brain, especially their frontal lobes, might make them makes them more at risk to have depressive symptoms. So seizures can cause more difficulties with thinking, worse frontal networks functioning, which can make it more likely to have depressive symptoms because this lovely limbic system that's generating a lot of unhelpful emotions goes unchecked. And if you resect an area, you're further disrupting this, the middle temporal lobe in terms of its emotional functioning, and then possibly further disrupting the frontal lobe. So it's just risk after risk when it comes to an epilepsy surgery as it relates to mood and cognition. And there's ways, I don't want to sound or create fear around epilepsy surgeries. It's more knowledge and awareness around properly being prepared and monitoring for these potential consequences, which neuropsychologists are generally fairly good at predicting. And a helpful evaluation with the neuropsychologist can speak individually to each of the associated risks from a cognitive as well as emotional perspective. And cognitive just means all the other functions like attention, motor, language, visual, spatial, etc. And then the limbic just means, and limbic and mental health just refers to the more middle parts of the brain and the middle parts of the brain function. So with epilepsy surgery specifically, again, very limited literature, but it's not uncommon for depression to onset usually within a month of a surgery and can last for more than 6 months. And sometimes it doesn't go away, which is roughly for about 15% of people, which again is not small. That's between 1 in 10, a little less than that, 1 in 8 patients with postoperative depression will have persistent depression symptoms more than 2 years later. That's not insignificant, and that might significantly impact their quality of life or the way that they would view the resection as successful or not. Oftentimes, anxiety might immediately spike after a resection, but usually it returns to baseline within 2 years, but it doesn't always. And individuals can persist with emotion regulation issues or persistent emotional symptoms as a result of having seizures or having their seizure, the parts of their brain where the seizures were coming from removed, which then changes how the brain creates, manages, and processes emotional responses. And it's certainly not a personal shortcoming, it's direct result. This is why my slide on the bad programming is so relevant. if you don't have that brain region, or it's being shocked with epilepsy and surged with seizures, it's not going to work as well. It's very simple, and it's certainly not because a person's not trying hard enough, because they're weak, because they're lacking in any capacity. It has nothing to do with a person's volition at all. It's just the hardware. It's just how the brain runs. Now, as I mentioned, psychotic disorders are very rare. Only about 3% of patients, especially with surgical aspects. And it's usually more limited to certain types of pathologies. This is just a dysembryonic neuroepithelial tumor, which is related to a rare form of epilepsy, or more developmental epilepsies like a focal cortical dysplasia, or a family history of psychosis, or specific aspects of personality disorders. Right temporal lobe seizures are at a higher risk of psychotic disorders, and certain aspects within the psychotic spectrum, especially hyperreligiosity or becoming hyperfixated on religion, but it is more rare and not as pervasive as anxiety and depression, which is why I'm not spending as much time talking about it. Okay. So similarly to general mental health identification with epilepsy, we want to be sure to consider what is the lifetime history of mental health disorders. That tells us something about the brain's health and brain's function with and without epilepsy. Before epilepsy happened, what was happening in the limbic network? Was it overactivated with depression and anxiety symptoms before? Did a person have ADHD before epilepsy started? Meaning, were their frontal lobes even weaker before epilepsy started? Personality disorders are related to usually more severe limbic network dysfunction, and it's a more pervasive pattern of emotional dysregulation, where either emotions are more, all emotions, not just depression or anxiety, are more intense, or have difficulty, people might have difficulty recognizing their emotions or behaving adaptively in response to them, or how they communicate and interact with others, how they request and receive support, how they engage with other people. Are there a lot of boundary violations? Do they trust others? Are they avoidant? So it's not just someone feels sad or worried, but otherwise is feeling emotions typically and interacting with others normally. In personality disorders, it's more specifically related to emotional dysregulation and interpersonal dysfunction that are pervasive and really debilitating in a lot of cases, which suggests broader limbic network dysfunction, as well as usually pulling in some frontal lobe dysfunction. Also, family history might help inform what a person's risk is for having mental health comorbidities with epilepsy, especially if there's a family history of any suicidal behaviors or psychotic disorders. That might mean that genetically an individual might be more predisposed to having those symptoms associated with their seizures. And then lastly, you also want to assess a person's and their family's experience with epilepsy and epilepsy surgeries. What does everyone expect? What might happen if X, Y, or Z happens? If there's cognitive changes, if there's mood issues, if everything goes back to normal, how will everyone adjust to a person in terms of their employment, their freedoms, their family dynamics? All of those pieces might be impacted by an epilepsy surgery. Okay, and again, I reiterate the role of neuropsychologists, psychologists, psychiatrists, and epileptologists in treating all of these different pieces as it relates to epilepsy and mental health, depression, anxiety, emotion regulation, behavioral regulation, social and interpersonal interaction, cognitive concerns, mediating all of these. Basically, if cognitive issues are present, it doesn't help anything, and all of these mood issues become worse, as well as the unfortunate reality that having epilepsy can be traumatic, and it doesn't rule out that other bad things might have happened in people's lives that might be worthy and very importantly addressed in clinical care and clinical consideration. There are some things we can do to help modify this risk, which would be ideally helping to identify these and then educate people prior to any surgery, and then be ready for anything if it happens. And the goal is also a symptom-free state. So sometimes people might prophylactically be on a medication to support mood, especially if someone's at high risk. And then also be in supportive psychotherapy pre and post epilepsy surgery to help monitor for any mood symptoms and quickly address those when they come up. generally, the quicker you can address mood issues, the less chance they have to become entrenched, and the more the opportunity to build helpful pathways and helpful supportive structures within the brain to reduce the severity or impact of those symptoms. And again, utilizing an approach that's designed specifically for seizures and epilepsy can be really helpful. And I will say also, most therapists probably won't know about epilepsy or epilepsy surgeries, but if you give them a workbook, well, they feel a lot more comfortable and can help work through many of the different pieces of the emotional experience, and a lot of the skills cross-apply for them. So I'm happy to answer I think that's my last slide. That's it. So I'm happy to answer any of the specific questions, revisit any of the items or slides. Sorry if it was too neuropsychology heavy, but I'm a neuropsychologist at heart and can't help but talk about the brain and why and how some mood challenges might happen. Okay.
We do actually have quite a few questions coming your way here, Dr. Cotton.
Perfect. Let's see what I can answer. I hope I'm up to the task.
So I will actually begin with a couple questions that actually came to me directly. And one of the first ones that I saw was, what is the relationship between PNES in your realm of neuropsychology, and how might that be related to epilepsy and these moods? And for those of you who don't know, PNES, also referred to as pseudo non-epileptic seizures. Is that something within your scope, Dr. Cotton?
It very much is. It's actually part of a bread and butter for a psychologist or neuropsychologist work in an epilepsy department. I'm fortunate enough to work embedded within our epilepsy department at Northwestern. I didn't cover functional neurologic symptoms here. Essentially, can I share my screen again? It'll help.
Yeah, absolutely.
Okay. So put briefly, and scroll back. So put briefly, for non-epileptic seizures, if we think about the brain in terms of hardware versus software, hardware are large-scale things, generally the realm of neurologists, strokes, tumors, epilepsy. There's a problem with how something is working. Literally, like the hard drive of your computer is surging, or someone took a hammer to it, or there's something there that shouldn't be. Hardware issue. Then there's software issues. And most historically, mental health issues have been relegated or are more small scale. This part of the brain doesn't talk well with that part of the brain. We don't see anything wrong on the scan unless you do a research protocol and average it over multiple individuals, and then it gets really complicated. But there's not anything giant wrong on the traditional brain scan, and it's smaller scale. Non-epileptic seizures versus epileptic seizures. So epileptic seizures are a result of an electrical storm within the hardware of the brain. Non-epileptic seizures are a software issue. And the software issue happens in those autopilot networks. So a lot of our brain processes happen without our conscious awareness. We breathe, we walk, we talk, we think. All of that happens on just without our awareness, so that we can focus on important things like, how do we build this building? How do we figure out how to communicate or solve this complex math equation, right? But our autopilot keeps us efficient so that we can do other things, and our autopilot keeps us safe. I don't want to have to consciously calculate if that bus is at a speed that it's going to hit me and how and if I should move. I should just do it. But like anything within our body, if we have it, something can go wrong with it, right? You have a kidney, it can get disease. You have an autopilot network, it can get a glitch. So in non-epileptic seizures, there's a glitch in the autopilot circuitry, which is very hard to correct because you can't just consciously think, stop doing that. It happens back behind the glass where we shouldn't be poking around. And so it takes time and effort to start to uncover how and why that glitch is happening, and if we can redirect it. And most of the time we can redirect it. This workbook is also very helpful for non-epileptic seizures. It works for epileptic and non-epileptic seizures. There's greater emphasis on emotional identification and behavioral pattern recognition for non-epileptic seizures, because all of that helps us gain access to what's happening in that autopilot circuit where that glitch is now happening and causing symptoms that look like a seizure, but are actually due to a software glitch. It takes time and energy, but people generally do get significantly better and can regain control over that process, that glitch that has happened, and start to have less of an impact on their lives. Having epilepsy puts one at greater risk of having non-epileptic seizures, but non-epileptic seizures absolutely can occur without having any epileptic seizures. Make sense?
Yes, thank you.
Okay, perfect.
Here's a question. You might want to stay on this slide for this one, actually.
Oh, this one?
Yes. From a question in the chat, what would be a professional and/or personal way to start asking for supports in the mental health realm? Do they begin with their doctor? Do they begin with us? Where would you professionally ask people to begin that question?
I think that depends on each doctor's level of comfort and familiarity. If you want mental health support, the quickest and most effective way is to go to a mental health expert. If your epileptologist is particularly savvy or has asked you about your emotions or regularly checks in on that, then you can ask them, who do you recommend? And generally, epileptologists will have either a clinic that they work with or partner with and can guide you. Generally, they won't perform the evaluation themselves, but they can direct you to people that they've worked with who perform evaluations and have been helpful to other patients. Always working with with a mental health expert, specifically with these focus areas. You want to look for health psychology, also called behavioral psychology, behavioral health psychology, providers who suggest that they work with chronic pain or other chronic medical conditions or medical trauma, and who utilize evidence-based modalities, meaning these modalities work. We have literature and research that supports using these specific skills to help with mood issues. And you can ask someone in interview, you're not just at the mercy of whoever you happen to make an appointment with. You can also assess, do they seem credible? Do they seem to have experience working with people with chronic medical conditions? What's their approach to epilepsy? Are they open and able to learn about it, or do they have knowledge of it? What's their familiarity with CBT, DBT, and ACT that have evidence-based for mood issues, especially with epilepsy? Are they open to using this workbook that's specifically designed for epilepsy? All of these can help guide you to someone who might be the most helpful.
Thank you. It's always important to ask the questions and keep on asking questions until we find the answer that we're looking for, as well as the person that we might be able to best help us in that situation. Another question that came up was, how can we differentiate the medication being the cause for our anxiety to depression versus something that's already part of our existing condition?
That's a great question. Sometimes it can be answered and sometimes it can't. The most reliable way that it could be differentiated would be what we would call the temporal sequence, the timing. Did you have anxiety and depression before you started your medication? If it's yes, well, then that gets more complicated. If it's no, well, then that keeps it a little simpler. All right, no, you didn't have it before. Did it start shortly after starting that medication? Yes or no? Did it get worse if the medication got increased? Yes or no? And so all of these different pieces of considering what was present when can help us determine what might be more causative. Oftentimes, though, it's not that clear, and that's really hard. There's a lot of uncertainty and acceptance of uncertainty within medical management. I remember getting into medicine and thinking, this is, we know exactly what we're doing and it's all super clear and this fits in this box and this will go here. And then I'm like, oh my Lord, nothing goes in a box. We make a box and then the brain or body doesn't care and it all just gets complicated. And unfortunately, that's the reality. But there are things that you can look at that might provide cues, and having a conversation with your doctor might also be able to help assess, is this a common side effect of that medicine? Is there something in your history that makes you more vulnerable? What was the timing? Does it change if you stop your medication? Is the side effect worth the benefit from a seizure perspective? And these are all important questions and trade-offs to consider when it comes to selecting medications and the potential complications or side effects of them. I wish there was a more straightforward, yes, this, no, that answer.
Yeah, it's definitely true. There isn't always a true yes or no answer to a lot of these questions that are coming your way here. Another question that kind of came up, I'm merging a couple here together, but you mentioned earlier that there is almost like that of a cycle with emotion, memory, seizure activity, and thus the negative emotions. Is there a way to practice and strategize management of this at home? And as well as something that then they would have to come to someone like yourself?
So generally, it never hurts to do things on your own. However, it's always what I would emphasize is the level of care proportionate to the severity of symptoms. So someone who occasionally struggles with some aspects related to mood or depression, but they're still able to go about their daily lives, live full and complete lives, and their mood does not, or epilepsy doesn't interfere with it, great. Self-help, management, all the way. The higher up you go in terms of level of severity or level of impact on daily life, the higher the level of care should be from a mental health perspective. If you have someone who's not able to work, lost their job, struggling daily with really difficult emotions, that person should be working with a professional who can help guide them, who can support them, and offer strategies that aren't normal daily things. It's not normal to have to deal with a job loss and seizures. That's not you're stuck in traffic and need to be a little more patient coping strategy. It's bigger than that. And that's where having that extra support should help. So I would recommend a level of support consistent with level of severity. That makes sense.
Absolutely. A question that came up in the chat again here was, is there a relationship between depression and hyperprocessing while also experiencing epilepsy?
Yeah.
Someone was sharing their story about how they naturally recognize and process information a little bit faster.
Yeah. So especially in left temporal lobe epilepsy, people can talk very quickly or be hyperverbal because the left temporal lobe is responsible for our language. And if it's overactivated, meaning epilepsy is an overactivation aspect, individuals can have that as one of their symptoms. The way in which the brain chooses to focus on things or how quickly it focuses on things is largely mediated by the frontal lobes. So if their epilepsy has involvement with the frontal lobes, that can also change the rate or way in which a person processes or perceives they process information. So yes, that can definitely be related to the epilepsy networks in the limbic, especially left language. For most people, 90% of individuals are left dominant for the brain and language, and the frontal lobes when it comes to selecting information, processing information, and then the perception of information processing.
All right. And just for sake of time, we might be able to have maybe another question after this, but the social stigmas at home and understanding whether or not when someone is experiencing memory challenges and differentiating that between just selective hearing to that of an actual memory challenge, how might we be able to identify some of that?
Yeah, so that's where a neuropsychologist, this is such an important topic. There's the question of objective cognitive impairment that's responded to normally, and then there's normal cognitive impairment that's responded to abnormally, right? So if someone's having cognitive issues, the best place to always start is with a neuropsychologist. Full disclosure, I'm biased, but really that's actually what we do and what we're specialized in. We're the best people to assess that. Ideally a board certified one if you can find one, that can assess what is your thinking abilities? What are your memory functions? When are they vulnerable? Are they below what they should be in terms of your age and education? And that can help start the conversation with family around expectations. No, really, they're not just forgetting. It's not just a lapse. They really can't remember. And that can answer those questions. And ideally, families will be healthy about how they understand, incorporate that information into family dynamics. and how they problem solve around those challenges. There's also cognitive rehabilitation, which is another wonderful resource for individuals with epilepsy and who have any cognitive associated challenges, but it's not particularly exactly mental health, but cognitive rehab is great. For families who are just not understanding of the cognitive challenges, then again, it's that level of severity of, well, then you should be pulling in family therapy to talk about family dynamics and expectations to help families be as adaptive to an individual's with epilepsy's challenges as possible, proportionate with the level of dysfunction. Occasionally your loved one, misunderstands when they're stressed. All right, you can probably address that yourself. Your loved one belittles you or doesn't understand or repeatedly blames you for your memory issues, might need to pull in a professional to help change their perspective or optimize how they might perceive things, or help you manage strategies to interact with that person in a way that's still supportive and helpful, or maximizes you getting the support that you need and minimizing any negative consequence of those interactions. It's kind of multifactorial depending on where is the issue.
Thank you. I know we're cutting it close here to time, so if you have a moment for one more question, I know we can't get to all of the questions throughout the chat here, but we'll try to do one more here, and then I will give back Dr. Cotton her time. One of the questions that just came up was, is surgery often delayed with children with epilepsy, considering how brain development and limited coping skills might be impacted, as well as such as their brain development?
Yeah, that's such a great question. And pediatric epilepsy is just such an important concept. There's a review article on my reading list. I just came across it on my listserv for pediatric epilepsy surgical outcomes, which might update this. I wish I would have read it before this, but I'm not a peds expert. But generally, the way that surgery is approached in pediatrics, it's a question of severity and risk versus benefit. So generally, if epilepsy is so severe that seizures aren't good for the brain. Every time that there's a seizure, it creates more likelihood of more seizures and worse seizures. And with further epilepsy, it creates decreased cognitive functioning and unfortunately damage to the brain with repeated significant seizures that are poorly controlled. So in certain cases, the risk of removing something and allowing the remainder of the brain that's healthy to flourish and adapt, the brain's marvelously adaptive, especially in children. The brain's growing and developing. It's actually very resilient in pediatrics, where it can then adapt around a change much easier than an adult brain that's stopped growing. Like once we're in our mid to late 20s, our brain's done, and then it's all downhill from there, unfortunately. But in pediatric brains, their brains can more easily work around a resection. So especially if epilepsy is more severe and there's a chance for seizure freedom, it's favored to let the brain remove the problematic piece and let the brain that's remaining and healthy adapt and overcome any of those limitations. And actually outcomes can be quite good for that. There are still risks, and it depends on the type and scope as well as other risk factors. But generally, pediatrics do better because their brains are more plastic, meaning they're more adaptive and have more adaptive potential.
Thank you so much, Dr. Cotton, for attending tonight and answering so many of our questions. I know we didn't get to all of them, but I do want to give you back your Tuesday evening as well. Thank you, everyone, for joining tonight, and we will continue to try to gather more questions and see how we can continue to answer and be a resource for everyone. Thank you, Dr. Cotton.
Thank you so much, everyone, for your time and attention. Bye.